This is a vertebral body, front, back, what we call in medicine anterior and posterior, up and down, cranially and caudally. The vertebral body, the disc, the foramen, spinal canal, and spinal cord goes through. The nerve roots are coming out there like my fingers, and then they come together. They become the sciatic nerve that goes down to the leg like my hand. Obviously, if there's a problem with the disc, there are multiple ways of dealing with that. And one of the recently developed method to get to the vertebral body is directly lateral. Many years ago, like in 50s and 60s, mostly people would go through the belly to get there. And then we started going mostly from the back, where we had to strip the muscle off the bone, take the facet off, and then get to the disc base. This is called DLIF, and you can find the reference to that. This is a big deal, destabilizing the muscle and so on. So DLIF was developed mostly by Nuvasiv, and please find the reference to that, almost 10 to 15 years ago. In the DLIF, patient is laying on the side, we call it the lateral position. Then table is broken, so we open up the space like this. Then an incision is done. Here is the skin of the belly on the lateral side, and then skin incision is done. Then under direct visual vision, a retractor is placed directly on the side of the vertebral body on the lateral position. The retractor has blades that are expanded, like my finger, and that gives you an access. Then the disc is entered, the end plates are prepared, the disc is removed, and then a cage goes directly laterally in. Obviously, in this position, first of all, patient has to be spaced laterally. The positioning is awkward. The positioning of sometimes people use microscope or X-ray machine. Because of the lateral position is awkward. So DLIF start actually as XLIF, what Nuvasiv developed, and DLIF is what Medtronic called it later on. Start picking up because the technical difficulty, though, I do believe it's declining. And please find the reference for that. If it's getting more or less, I think you can find those data. Either way, it is not finding widespread acceptance because of the technical and operative difficulty. Additionally, there are nerves root that come out here. They run along the lateral aspect of the vertebral body in what we call iliopsoas muscle, two muscle, iliac muscle and psoas muscle, we call them together iliopsoas muscle. So further down you get, it becomes increasingly more difficult to do a direct lateral approach. And practically is impossible with the usual technique in the 5S1, because here there is only one or two nerves coming out. Here there are two or three, and further you get more nerves are coming here that obscure your view. And because the disc replacer graft that it's put in is so big, practically it's very difficult in the 4-5, as almost impossible in the 5S1 through traditional DLIF to do so-called direct lateral interbody fusion. So what we are proposing in the MIS direct lateral fusion is, instead of positioning the patient laterally like that, breaking the table, and then after we are done, break all the sterile field, turn the patient on the back and do posterior fusion. And like most of other fusion, you need to perform a lateral and posterior fusion, like either facet or pedicle screws, to have additional stability. There are some lateral plates. The problem with the lateral plates is that they push even more on the nerve and cause more nerve damage. As well as most of the lateral plates, they have one screw above, one screw below, and that gives still some sagittal motion, allows some sagittal motion and cause instability. There are some, especially by Synthes, I believe, and Nuvasiv, plates that have two screws to give the 4-point fusion that is more stable. But again, those plates are so big that cause lots of more preparation and makes the surgery much more difficult. Now, in the MIS OLIF, what we are proposing is keep the patient on the prone and maybe a little more lateral airplane, so to get a better direct lateral approach. Like OLIF, position AP and lateral X-ray machines, so you get the AP and lateral view. Then make the incision on the side as the DLIF is done, and use the electrophysiological probe to approach the disc directly laterally. Then only with the direct fluoroscopic imaging, so without the direct visual, enter the dilator and then the OLIF tube. Then all the procedure is practically done over the OLIF tube. Because we are laterally and go traverse longer, we need to make sure that Amendia will build us a longer tube, as well as contrary to the oblique lateral where we go to the cambium triangle here. Here we go directly lateral, so we are not confined to the cambium triangle here, since we go directly laterally. Either way, when we go directly laterally, the rest of the procedure is done practically with the dilator, serial discectomy with the instruments and so on. Then after that, practically we do the posterior instrumentation with putting screws in the pedicles and finish it with the posterolateral fusion as we have been doing with the reference to our OLIF paper. Now, in the traditional DLIF, patient is laterally, bed is broken, disc is approached and entered, and then some people keep the patient there and put a posterior clamp. Posterior clamp has not been shown to be biomechanically very stable, and we should find some reference to that. I see that at least in our community that many of those patients come back to me for fusion. I just had a patient today that had the XLIF done the same way we talked about with the posterolateral clamp that hold the spinal processes. These are spinal processes for stability, but that wasn't enough, and patient has developed instability and non-fusion, and patient needs now revision. Some people as well have been doing practically some other devices to hold it back. They haven't gotten any traction, but most of the people then break everything, spend an hour to do in-surgery repositioning, then do pedicle fusion or facet screws, practically the way we do it for the our OLIF, after the OLIF part, the posterolateral instrumentation, not fusion. We do more than that. We do posterolateral fusion, not only instrumentation. Having said that, in our proposed way, we go directly laterally, and that's with a much smaller probe and on the direct electrophysiological monitoring. So that helps us to bypass the nerve much better. Because our probe and tubes are smaller, we can address 5S1 as well as 4-5 much better with the traditional, in comparison to the traditional DLIF. And as well, this is a good sort of rescue technique for OLIF, where the cambium triangle is so crowded that we cannot get the approach. Then we can, instead of going oblique lateral, we just drop with a longer tube, go directly lateral. So this is a good rescue for OLIF if the cambium triangle cannot be opened up, as well as for people who still like to do the DLIF or XLIF, it would give them much better approach to the 4-5 as well as 5S1, as well as in some insurance stances where insurance doesn't know and approve the OLIF, we can just practically go directly in the retroperitoneal space and do a DLIF and use the same instrumentation, same minimal invasive technique to achieve the same goal with much less trauma. The trauma in the direct lateral approach is significantly more because the skin need to be opened much more. The abdominal wall, which is practically here, need to be opened much more, as well as there is significant more opening on the iliopsoas muscle and the nerve that go through. In our technique with the electrophysiological monitoring, we just have to find one single empty space here, and the dilator push the nerve and with the muscle around it just to the side, because we are using this special dilator system. And practically, with just rotating of the table, we can achieve, that's all our positioning. Instead of breaking the sterile field, spent almost an hour just to reposition the patient and re-scrubbing and re-draping the patient. And this is the advantage of the MIS direct lumbar interbody fusion to traditional interbody fusion. And that's it. Do you have any question right now before we quit this?
No.
Okay.